Well, welcome everyone. Uh, really pleased to have this chance to welcome you to our program. And I'm especially pleased today to have a guest professor, Dr. Joe Rabban, who's professor of pathology at the University of California, San Francisco, and a well-known expert in gynecologic pathology. Um, and he's going to present some interesting cases and discussion, a very important and often challenging area in pathology of how do we manage the various questions that come up with endometrial biopsies, because that's our first interactive point. Joe has been to Southeast Asia. I think some of you have heard him speak at a recent conference in Hanoi, and so he will be a familiar voice for many of you. But with that, I'm going to turn the time over to Joe, and we will entertain questions at the end of the discussion. If you want to type them into the chat, that'll be fine, or we'll have some time for interactive audio questions as well.
Well, thank you very much, Liz, for the introduction and for the opportunity to speak with this audience. I'm very excited about this. I um, I find a lot of enjoyment and fulfillment of looking at material with folks from different places in the world because we're all looking at the same types of diseases and processes, and we may have slightly different lenses, but we really are a single community, even though we may be in very different time zones. And so um, it's an honor to be invited here. So as Dr. Hassel said, my cases are all centered around endometrial biopsies because this is the starting point um, for deciding whether a patient's journey is going to involve management of a neoplasm or whether the biopsy does not merit any further workup. And so these cases are a little bit different than looking at hysterectomy-based specimens because there's this special management issue, and I'm going to highlight some of those management issues with some of these cases. The first case is a 45-year-old with uterine bleeding who underwent endometrial biopsy. And this is the tissue that we get. And I'll just say at the outset, the first thing that I do when I look at an endometrial biopsy is I assess, number one, do we have intact glands and glands and stroma? Because in order to assess for precursor lesions to endometrioid cancer, you really need to have intact glands and stroma. And if you don't, then it becomes very difficult to do that, and you go down a different pathway for analyzing and reporting the specimen. So I would say in this specimen, we do have plenty of intact fragments of glands with stroma. There's a little bit of a spectrum of what we see. Some of the fragments in the center, we can look at the gland to stroma ratio, and it looks relatively balanced, or 50% glands, 50% stroma. And so this is our sort of reference point of what proliferative pattern endometrium should look like. However, when you start moving to a couple other fragments, we notice that the gland density has increased. And before even going to higher magnification, this is an indication to me that we have a very specific differential to consider. So gland crowding, meaning the ratio of glands to stroma is higher than 50-50, comes with a differential of hyperplasia with or without atypia, a grade 1 endometrioid adenocarcinoma, endometrial polyps can have increased gland density. And then the final thing that people tend to forget about is normal secretory pattern can have, almost by definition, increased gland density. So these are the four things that I would be thinking about as I'm scanning through the case. We'll just say right off the bat, because we have endometrial stroma in between these crowded glands, this is not grade 1 cancer. Grade 1 endometrioid carcinoma is defined by the absence of endometrial type stroma between these glands. So right away, we can comfortably say there's no concern for cancer here. So now the question becomes, which of those other three entities do we need to think about? Um, let's just look at a couple more fragments before we start to make an assessment. Here's another fragment. Another thing that you can notice with this increase in gland density is it tends to have a very, I would say, demarcated border to the area. So it's not that all of the fragments are showing um, increased gland density. It's kind of a focal or discrete process. So, are there any features of endometrial polyp? Well, we would look for enlarged thick-walled vessels. I don't think we see any. We'd also look for fibroblastic type stroma. We don't see any here. So I think we can narrow our differential down to some form of hyperplasia versus secretory endometrium. But when we look at the glands, they have tall columnar epithelium. There's no vacuoles. So this is not secretory endometrium. I think we can comfortably arrive at the diagnosis of hyperplasia. This degree of gland crowding is too much. So what is the cut point of when we draw the line of saying that the gland crowding is beyond what you would expect for, let's say, disordered proliferative endometrium, or if this were a polyp, you can have some range of crowding. The answer, unfortunately, is that there is no answer. Despite multiple attempts to come up with criteria over many, many decades, we don't really have a reproducible way of defining how much crowding is enough. So we can't make a measurement, we can't look at the surface area, it becomes very subjective. And so one of the rules of thumb is to set a cut point of somewhere around 65 to 70% of the fragment being occupied by glands. That's the minimum cut point that most people use to say this is too much and we should call this hyperplasia. So I chose this case because I think this is probably the most minimal amount of gland crowding that I would accept to cross the threshold and to call this endometrial hyperplasia. So the next thing that we need to do is determine whether it's atypical or not. And the historical WHO, World Health Organization criteria ask us to look at a couple features. So we would look for round to oval nuclei. We don't have that here. The nuclei are elongated. We would look for loss of polarity. Well, we do have a little bit of loss of polarity, so maybe we have one criteria here. We would look for vesicular chromatin, meaning that there's white space or chromatin clearing. I don't see any of that here. And then the fourth criteria would be macronucleoli. And I don't really see any macronucleoli. So the only issue here is a little bit of stratification, but you really need to have two or more of these WHO criteria to call this atypical. So overall assessment for this case, endometrial hyperplasia without atypia. And so this is just a reminder of the criteria by the current WHO. You need to see increased gland to stroma ratio. And as I mentioned, unfortunately, this is subjective. And so most people put their cut point somewhere around 70 or 65 to 75%. And you want to try to see whether there's a distinct demarcation of that area compared to the background. You can get either tubular or glandular glands. You can see branching or sometimes cystic dilatation. And then this would be the main differential. As I mentioned, disordered proliferative pattern can have some degree of crowding. We'll talk about papillary proliferation of endometrium later. This case did not have any papillary features. That's why I didn't mention it up front. And then finally, you want to be careful if you have stromal breakdown, because if there is breakdown of the tissue, the glands can collapse in on themselves in the biopsy, and you get an artifactual type of crowding. So if you do see stromal breakdown in the area of crowded glands, that is probably an artifact and not true hyperplasia. And then obviously we need to make sure that there's no atypia. And one of the pitfalls is if you see tubal metaplasia or eosinophilic metaplasia, sometimes that can be overinterpreted as atypia. And then another question that folks who are my age or older ask, because this was something when I was in training that was one of the rules, we no longer need to distinguish, is the hyperplasia simple versus complex? This has no significance to management or prognosis. So we just call this case endometrial hyperplasia without atypia. Coming back to this issue of how much crowding is enough, this is something that I think pathologists have been asking throughout uh, the last century, and there's no easy answer. And so this is a cartoon diagram that I prepared to help my trainees understand where the cut point of 65 to 75% is. So I created these little diagrams and going from 50% to 75%, that is the cut point that you want to start thinking about. And so this is just to give you an idea of, in a tissue biopsy, what the level of crowding should look like. So let's move to case number 2. This is a 45-year-old with uterine bleeding who underwent biopsy. Um, we have some fragments of endometrium, lots of superficial myometrium here. And let's just go over to this one because right away we can see that there is some gland crowding. And as we go in a little bit higher magnification, we can see that there is still endometrial type stroma in between almost all of these glands. So this is not to the degree where we need to be wondering about carcinoma. But I do want to point out that as we are getting a little bit higher magnification, we can already start to appreciate there's a cytologic difference between the cells in these crowded glands and the appearance of the epithelium in the non-crowded glands at the periphery. So what is the difference? If we look at the non-crowded glands, we can see that we still have somewhat of an elongated shape to the nuclei. There's a little bit stratified, but when we come over here to the area of crowding, you can see a nice visual difference between the two. The shape here of the nuclei is oval to round. There's some chromatin clearing. There's loss of polarity. And there's a beginning of a presence of nucleoli. I wouldn't say these are the largest nucleoli that I've ever seen, but we are starting to see some chromatin condensation here. And so I would say that this is a discrete focus of endometrial gland crowding, so it qualifies as hyperplasia, and we have a cytologic difference between the epithelium in the crowded and non-crowded glands. So this I would classify as atypical endometrial hyperplasia. So what is the definition in the current WHO? It's basically hyperplasia with cytologic alteration that can be recognized in comparison to the background non-crowded glands. Now this definition also comes with some subjectivity. Back in the 4th edition WHO, for those of you who may have been around, they had some very nice criteria. These are the criteria that I mentioned as I was walking through the case. Round to oval shape, nuclear enlargement, loss of polarity, vesicular chromatin, macronucleoli. In the 5th edition WHO, these criteria were no longer mentioned, and they simply said you need to look for a difference between the cytology of the crowded glands to the background. One of the difficulties with this definition is that the cytologic alterations of many forms of metaplasia, in particular tubal and eosinophilic metaplasia, can be misinterpreted. And so I tend to rely on the original criteria from the 4th edition. Now, if I took an audience poll, some of you may raise your hand and say that in your center you may use the alternate precursor terminology of endometrial intraepithelial neoplasia, or EIN. This is a parallel system that was developed at the Brigham in the early 2000s. We don't use it in my institution. I'm not going to really talk about this other than to say that the criteria are very, very close to the criteria that I'm showing here. The other comment that I'll make, just so that you are aware, or maybe some of you are actually using this, there are recent studies that have shown that some immunohistochemical stains can be used to supplement your assessment for atypical hyperplasia. The immunostains are the ones listed here, P10, beta-catenin, and PAX2. The challenge with this is that PAX2 is an antibody that most laboratories don't have. We no longer have this antibody. P10 is very finicky and difficult to interpret. Same thing for beta-catenin. So many people ask me, do we use any of these immunostains? And the answer is, in our practice, we do not, but there are some practices that are using this to help separate atypical hyperplasia from metaplasias. So just a reminder, why is this important to identify atypia when you have hyperplasia? The reason is the risk of progression to cancer. The literature shows that if there's atypia in the hyperplasia, anywhere from a quarter to half of those patients are ultimately going to progress to carcinoma, and therefore the recommended management of atypical hyperplasia is a hysterectomy. Whereas if it's hyperplasia without atypia, the risk of progression is too low to recommend this, and so these patients are mainly managed to help suppress the bleeding, so usually hormonal intervention. Okay, case number 3. This is a 50-year-old with uterine bleeding who underwent endometrial biopsy. At low magnification, we can see already there's a lot of glands here. It's a much more complex specimen than the last one. The main alteration that we're seeing is increased gland density. But as we scan around, we can appreciate there's still endometrial type stroma between most of these crowded glands. So at least right now, we don't have to worry about carcinoma. But then when we come to some of these fragments and we zoom in, it's now showing some of these glands are losing the endometrial stroma between them. So here it's almost getting a little bit, I wouldn't say cribiform, but it's kind of getting complex architecture. And so the point here is, where do we draw the line between atypical endometrial hyperplasia and a grade 1 carcinoma? Well, we know from a qualitative standpoint, it's simply the loss of endometrial stroma between the glands. So you could come to a focus like this and you can say, well, it looks like these glands are fused. There is no endometrial stroma between the glands. Therefore, I'm going to call this cancer. I would say this is too small. Just to have a couple glands fused like this is not enough. So the question now becomes, where do you draw the line? And again, this is one of the dilemmas in gynecologic pathology. There are no outcome-based studies that can provide an answer. So we can't say that, okay, if you have 5 glands that are fused or 10 glands, or you have a focus that's half a millimeter in diameter, none of those criteria really have any outcome-based justification. And so, unfortunately, this becomes a subjective matter in the eye of the pathologist. The reason that I'm showing this case is because I do think that there are areas that are concerning for carcinoma um, by these little focal areas of loss of the stroma. And it turns out that there is at least one very nice study that says when you have atypical hyperplasia with these suspicious foci, the risk of cancer in the uterus is higher than if it's just regular atypical hyperplasia. And so the recommendation from the International Society of Gynecologic Pathology is to call this out in your report, to call this atypical hyperplasia with features bordering on carcinoma. The reason that this is important to communicate when you're worried that it might be cancer, but the findings are not definitive for cancer, is that it alerts the clinician if they're thinking about giving hormonal therapy, they may want to think twice if we are telling them here that this is potentially carcinoma. So, diagnosis for this case, atypical hyperplasia bordering on grade 1 endometrioid carcinoma. This is a case that I'm worried could be cancer because there's focal loss of the intervening endometrial stroma, because the branching and the cribiform-like growth is starting to become developed. However, there's a number of reasons why I wouldn't call this one carcinoma. It's too small, acknowledging that there is no reproducible definition of the minimum size. Other cases, the problem might be that the specimen is too fragmented, and sometimes, like in some of the areas I showed you, it's questionable whether you really have loss of that stroma. And so, again, you may be worried that it's cancer, but it doesn't fulfill criteria. And so the important message is to get that into the diagnosis. This is data from the paper that I mentioned showing that in this series, um, atypical hyperplasia without concern for cancer, 40% chance of cancer in the hysterectomy. If there is concern, much higher. And so therefore, the ISGIP recommendation is to use some wording in your final diagnosis. I've given a couple examples of how you can word it. Um, I'm sure the language is different in different parts of the world, but the idea is to communicate your concern in the pathology report. Okay, case number 4. A little bit different history this time. This is a 38-year-old who recently was diagnosed with grade 1 endometrioid carcinoma, but they wanted to preserve fertility, and so the patient has been managed with progestin. And so in this situation, the clinicians need to do a surveillance biopsy every 3 months to make sure that the pathology is responding to the progestin. So we're going to look at a surveillance endometrial biopsy. So we do have some intact glands and fragments. And when we look at the gland density, I would say it's a little bit higher than 50%, sort of. The other thing that you can see already at low magnification is there are these very irregular contours, not only to the outer contours of the glands, a little bit of outpouching, but there's also some internal folding of the epithelium. So a little bit unusual architecture here. And then when we zoom in some other areas, we're starting to get crowding, and it's starting to look like there's some loss of the endometrial stroma between the glands. So this is very concerning. As we scroll around, we can also appreciate something that we didn't see in the other slides, which is pseudodeciddualization of the endometrial stroma, and this is due to the progestin. So the reason I'm showing this case is to talk about how do we evaluate surveillance biopsies in patients who are being given progestin for either atypical hyperplasia or a grade 1 carcinoma. These are tricky cases because the progestin, by definition, is going to suppress the hyperplasia or the carcinoma. The progestin can also suppress the cytological alterations. And so if we come down again and we look at these epithelial cells, I don't think that there's any atypia here. The problem is this may be atypical, but it's just being suppressed by the progestin. And so the bottom line is that the rules that we use for classifying surveillance biopsies in the setting of progestin are different. And so I'll show you a table with the criteria, but basically any type of crowding, branching, funny looking glands should be considered residual disease. The name of how you sign out this case is not really relevant. The most important thing is to compare how much abnormality you have in the current specimen to the most recent one. And all the clinicians are looking for is a trend over time that the amount of abnormality gets less and less and less with each successive sample. So this is a case that, I don't think it really fulfills criteria for cancer. At the same time, using standard criteria, it doesn't fulfill criteria for atypical hyperplasia. I think it would be very odd to call this hyperplasia. It just doesn't look like a discrete focus. And so this is why I'm saying we can't really use conventional criteria here. The only thing that matters is that we have funny looking glands, and that's enough to make the diagnosis. So I would call the top line here residual progestin treated endometrial glandular proliferation, something along those lines. These are the criteria in this table from this Wheeler paper, which is the best paper on this topic. If you see any one of these architectural changes or either of these two cytologic features, you should consider that residual abnormality. So how do we deal with the reporting? As I mentioned, the first thing to ask is, do the features meet classical criteria for cancer or atypical hyperplasia? If the answer is yes, then you can use those terminologies, and I would use the word residual progestin treated in front, just so everybody knows that this is a patient under surveillance. But if the findings are not classical, then you can use a more descriptive terminology. In either case, you want to make sure that you do two things in the diagnostic comment. You want to document that you retrieved the glass slide of the prior biopsy, that you looked at it, and then you want to document, is the current case in terms of abnormality the same, less, or worse? If it is worse, then the clinician is probably going to entertain doing a hysterectomy or counseling for a hysterectomy. If it is less or the same, then they will take that as a signal to continue with progestin treatment and resample in another 3 months. And then let me go back and say, the idea here is that around 9 to 12 months, if they can get the endometrium to a state of complete atrophy, then the patient can consider trying to get pregnant, have a baby, and then afterwards have the hysterectomy. Okay, case number 5. This is a 38-year-old with endometrial polyps that were identified during a workup of fertility, and so they did endometrial polypectomy. This is the sample. You can see at low magnification already, we have some irregularly shaped glands. So let's take a look at higher magnification. The irregularity seems mostly to be papillary infoldings inside dilated glands. Um, let's go a little bit higher magnification. We can start to see some very unique features to these papillary infoldings. To my eye, the very first thing that I notice is that the nuclear features are uniform. We don't really have nuclear pleomorphism, hyperchromasia, or abnormal looking mitotic figures because the combination of that plus papillary architecture would make me think about a serous carcinoma, or if there were clear cytoplasm, maybe a clear cell carcinoma. But we don't have any nuclear abnormalities. What we do have is a mixture of cells, some that have eosinophilic cytoplasm, others, like over here, that seem to have mucinous cytoplasm. This is a very unique type of alteration, typically occurs in polyps, and this is referred to as papillary proliferation of the endometrium. I chose this slide because it actually is one of the most striking examples that I've ever seen of this. This alteration in and of itself is totally benign. The problem is that there is a risk that it can coexist with atypical hyperplasia or grade 1 cancer. So this is one of these diagnoses that we need to make sure the pathology report signals to the clinician, even though this is benign, they probably need to do further evaluation to make sure there's no undersampled cancer or hyperplasia. And I've learned in my career to be careful in my pathology reports not to tell the surgeon what to do because most surgeons don't like being told what to do. And so I usually use wording such as further clinical evaluation is merited to exclude the possibility of undersampled cancer. That way, I'm not saying I recommend a curettage or I recommend hysteroscopy. I think many clinicians don't want to be told what to do by the pathologist. So finding alternate wording is a good thing. So I'll just show you a couple more areas here. I think that before the 2 papers on papillary proliferation of endometrium were published, many pathologists would view this as a form of hyperplasia, complex hyperplasia. And I think that that's a reasonable way of thinking about it. But by recognizing the association with undersample cancer, the term papillary proliferation of endometrium has a more functional role than just calling this complex hyperplasia. We need to signal to the clinician that something more needs to be done. So this is just a summary of the definition. Architecture can be simple or complex. This case that I showed you, I would definitely call complex. And then, as I mentioned, the nuclei are bland. There's no abnormal mitoses. You typically get 2 different cells, mucinous and eosinophilic. And in my report, I usually document these numbers of what the risk is to having undersampled or concurrent disease. And then these are the 2 references that you can put in the path report. I think the management is a little bit different depending on whether it's in a biopsy versus a hysterectomy. Obviously, if you find it in a hysterectomy, it's moot. There's nothing more to do because you have the entire hysterectomy. The place that this diagnosis becomes most important is if you're looking at a biopsy or a polypectomy, because this is the setting where they need to probably go back and do a curettage. Okay, case number 6, 65-year-old with uterine bleeding who undergoes endometrial biopsy. Um, Low magnification, it seems like we have some uh, cellular pieces of tissue starting to show kind of a glandular, little bit of a branching appearance. One thing that I will note that we have not seen in any of the other samples is, in addition to the epithelium, we have necrotic debris. Necrotic debris is a worrisome finding in an endometrial sampling. Um, it doesn't mean anything on its own, but it should make you think about whether you're dealing with a neoplasm that might be on the higher grade side of things or might be myoinvasive. So the architecture that we're looking at seems to be somewhat glandular, maybe a little bit bud-like, um, so maybe some mild branching. As we look at the nuclei, we're starting to see variability of the size and the shape. And then look at these very prominent cherry red macronucleoli, accompanied by many, many mitoses, some of which are atypical mitoses. Um, the specimen is a little bit fragmented, so it's a little bit hard to comment on gland density. But as we kind of move around, we can appreciate that this is more than just simple glands. They have a little bit of papillary infolding. The reason that I wanted to show this particular case is because um, you may be thinking, oh, this is some permutation of an endometrioid process. Maybe we're looking at endometrioid carcinoma. But in fact, this degree of macronucleoli, the high mitotic index, the atypical mitotic figures, we're actually looking at a pseudoglandular pattern of serous carcinoma. And coming back to this necrotic debris, as I mentioned, I would not expect this much necrotic debris in a grade 1 endometrioid carcinoma. And so this is another clue that we're dealing with something high risk. So this is an example of pseudoglandular pattern serous carcinoma. It falls under the umbrella of high-risk mimics of low-grade endometrioid cancer, the so-called wolves in sheep's clothing. And I've listed here what is now a growing list of tumors that are high risk because they have aggressive behavior, but their architectural features can be mistaken for low-grade endometrioid cancer. And I will point out on this list is one tumor that doesn't even originate in the endometrium, and that is HPV-associated cervical adenocarcinoma. We always have to remember that some patients may have extension of cervical tumor into the endometrial cavity. And so when you have a bunch of mitoses, particularly floating mitoses, in other words, mitoses that are in the cytoplasm and the apex of the cell, you want to think, could this patient actually have cervical adenocarcinoma? So the one point that I will emphasize is how do we distinguish endometrioid carcinoma that's grade 1 from this pseudoglandular serous carcinoma? And it really comes down to comparing the architectural grade and the nuclear grade. So by architectural grade, I mean just simple glands and branching as opposed to solid growth. So for grade 1 endometrioid cancer, both the architecture and the nuclear grade are low, so they are concordant. The key to remember or to look for in pseudoglandular serous carcinoma is that the nuclear grade is high, whereas the architectural grade is low. So what are the nuclear features to look for? They're the ones that are listed here. Now, this is one of these diagnoses that I remember as a resident going to lectures and hearing speakers say you have to always be worried about pseudoglandular serous carcinoma. And I have to say that as of today, 2026, this still remains a major problem. It's a sneaky diagnosis. I could actually spend an entire lecture talking about this, but I just wanted to put this on your radar. If you are about to sign out a case as grade 1 endometrioid carcinoma, make sure you really look well at high magnification to convince yourself that you're not seeing any of these high grade features, and that will help you um, uh, reduce the chance that you are under recognizing one of these glandular pattern serous carcinomas. Okay, next case, 65-year-old with uterine bleeding undergoes endometrial biopsy. The first thing to note on this specimen is there's not a lot of tissue. And I always get worried when I have cases like this because there might be something very, very focal in here that is very important, and we don't want to overlook it. So the the other problem with this sample is that the epithelium is not really intact with the stroma. And so when we look at these fragments, it's kind of underwhelming. We have strips of epithelium. The nuclei are relatively uniform. There's no atypia. I'm not really seeing any abnormal mitotic activity. And so you might think, okay, this is no big deal. It's just some strips of epithelium. Let's move to the next case. But notice what's going on in the cytoplasm. There is abundant mucin here. We normally do not expect to see this much mucin in the endometrium. Where might you see this amount of mucin? Well, how about the endocervix? So one possibility is that what we are looking at here is contamination of the endometrial specimen with endocervical epithelium. It is a little bit cribiform and branching, and so maybe this is microglandular endocervical hyperplasia that is contaminating the endometrial biopsy. The teaching point here is that that is a uh, age-sensitive diagnosis. Microglandular hyperplasia is something that we expect in premenopausal women. I told you this is a postmenopausal age patient, and so it would be very unlikely that they have microglandular hyperplasia. So what's the alternate explanation of what we're looking at here? The alternate explanation is that there are some forms of low-grade adenocarcinoma in older women that have microglandular-like features. And the question is that what we are looking at here? And that may be an undersampled type of specimen, or are we looking at benign microglandular hyperplasia? And the answer is we cannot tell the difference. If you happen to see reserve cells underneath this columnar layer, that would tell you you are in the transformation zone, but we don't have any reserve cells in this field. So this is a sneaky case because it looks pretty innocuous, it looks pretty bland, but this is a dangerous finding. And in my experience, there's a pretty significant chance that if they go back and resample the patient, they'll find bona fide grade 1 carcinoma with mucinous or MGH-like features. So the teaching point here is to be very, very cautious when you think that you are looking at microglandular hyperplasia. There's a very good chance that it's not. And so I use a top-line diagnosis here that's descriptive. I call it complex mucinous glandular proliferation. And in a comment, I say there is this possibility of cancer, and so further workup is advised. Case number 8, 50-year-old with uterine bleeding who undergoes endometrial biopsy. This case also is a little bit unsatisfactory because there's a lot of just fragmentation of the tissue, not a lot of intact glands and stroma. But I wanted to show this because there are some features that sort of pop out as we're scrolling around. So this is one of those fragments. It's a round nested proliferation of polygonal cells, bland nuclei, abundant cytoplasm, maybe a little bit of necrosis in the center. And I think if we keep scrolling around, we're going to find more of these. And so the question is, what are these structures? Okay, here we go. They're kind of sneaky, but once you see a few, then it's easy to see additional ones. These are areas of morular metaplasia. Morular metaplasia on its own is benign, but it's the same situation as papillary proliferation of endometrium. These do have a risk of being associated with a low-grade carcinoma or developing carcinoma over time. And usually, these morules are sitting within complex crowded glands. I wanted to show this example because these morules are not sitting in glands, they're just free floating, and they're very easy to miss. Here's one that has central necrosis. So the question is, what do we do when we see morular metaplasia in the endometrium? Well, first of all, we want to make sure that in the intact glands, we don't have any evidence of hyperplasia or carcinoma. I don't see any here. This is probably a polyp, I think, because of the fibroblastic appearance of the stroma. Here's another very beautiful detached moriole. So, um, and then actually there's many, many more. And this is one of those things that if you're not thinking about it, you can easily overlook this, maybe even think that these are just histiocytic aggregates. Um, so, modular metaplasia, as I mentioned, solid nests, very, very bland cells. They can be free floating. Clinical relevance, as I mentioned, is that they can be associated with atypia or cancer. And so the way to report these is, number one, make sure your final diagnosis includes the words modular metaplasia somewhere. Document the risk. These are the two papers that I would cite and recommend that they rule out undersampled abnormalities and then undergo long-term follow-up. Okay, case number 9, 39-year-old with uterine bleeding and polyps, undergoes polypectomy. We have many fragments that just look like superficial myometrium or perhaps submucosal leiomyoma. This is an area that catches my eye because the glands are crowded. As we go to a little bit higher magnification, we can see there's still stroma in between the glands, so nothing here that would qualify for carcinoma, but they are crowded. And then we see, guess what? More morioles. So this is a very similar finding as the last case. However, here they are embedded within crowded glands. If we look at the stroma in between the glands, I think that this is a type of appearance that we haven't seen in any of the other cases. This looks very much like smooth muscle. And so collectively what we have here is an atypical polypoid adenomyoma. This is basically a polyp that has smooth muscle type stroma, and the atypical part of it is that we have crowded glands with morular metaplasia. Um, you don't always get to see cytologic atypia in the hyperplasia, but that's okay. This is still criteria, what we're seeing here, to make the diagnosis of APA. Um, so APA, I've mentioned the criteria here. The reason that this is important is because of the clinical relevance. Usually this is seen in the third and fourth decade. It usually forms a polypoid lesion in the lower uterine segment. These are patients who often want to preserve their fertility, and so there's very good data showing that if the surgeon can locally resect the lesion, then they can proceed with fertility sparing approach. However, a small percentage of these will progress to endometrial carcinoma, so the clinician has to be very careful about this. The other reason that I think this is an important lesion to know about is because you might, if we go back to the H&E, you might misinterpret that the presence of these glands in a background of smooth muscle, you might misinterpret the smooth muscle as being the myometrium, and therefore, oh, I have individual glands percolating through the myometrium. This is myoinvasive grade 1 endometrioid carcinoma. So that's the pitfall with this diagnosis. The good thing to remember is that an endometrial sampling is rarely ever going to be getting into the myometrium. So it would be very unlikely that you would ever see evidence of myoinvasive cancer in a curettage, even when it's present. So most likely when you see this type of smooth muscle, it's within a polyp. It does not represent the actual myometrium. Okay, case number 10. This is a 45-year-old with uterine bleeding, found to have polyps, which are removed. This is a really, I think, striking illustration here. Two different growth patterns that we have not seen in any of the other biopsies. The one that really jumps out is this kind of broad papillary architecture. It's very reminiscent of fibroadenoma or phylloides tumor of the breast. And so right away, this architecture brings up the concept of adenosarcoma of the uterus. And if we look at the cytology, we can see that the overlying epithelium is benign or bland, but we have a very cellular proliferation right underneath the mucosa here. It's not really severely atypical, but there's a certain plump shape, enlargement here that is more than what we would expect in a polyp. This is a well-developed enough and large enough focus to classify as adenosarcoma. There's a second growth pattern here that is much more sneaky, and that is the presence of these simple glands that are surrounded by a very, very subtle increase in the cellularity of the stroma. Um, on its own, this would be very difficult to recognize as adenosarcoma, but this is that second pattern of periglandular stromal condensation. It's not the world's best example, but I wanted to show it just to emphasize that this can be a very subtle diagnosis if you do not have the leaf-like features. What do you do if you don't have convincing features to confidently call it adenosarcoma? There's very nice studies showing that if the findings fall short, simply call it an atypical polyp, and the data shows that um, those cases, as long as they're under 3 centimeters, are not going to recur. So for adenosarcoma, the other point that I wanted to raise is that you may not see mitotic figures, and that's okay. As long as you have the architectural features, that's enough to make the diagnosis. The other thing that I would do when you sign out the case is look for the prognostic variables of stromal overgrowth, which is defined as areas in which at least a quarter of what you are looking at doesn't show any glands. It's just all stroma. And then you also want to look for pleomorphic nuclei. These are two things that are going to have a little bit worse prognosis. And then just a reminder that the fifth edition decided to remove the entity of adenofibroma because these are felt to actually just be adenosarcomas with a very, very low level of risk of recurrence. And then as I mentioned, if you are looking at a specimen that only has focal features, the data shows that you shouldn't just outright call it adenosarcoma because the behavior is not going to align with that. It's better just to discuss the concern, but to ultimately refer to it as an atypical polyp. Case number 11. This is a 45-year-old with uterine bleeding who undergoes endometrial biopsy. At low magnification, doesn't really look like we have any intact fragments of glands and stroma, but we do have these solid components here. So let's take a look at these nests and strips of cells. Some of these have a rounded configuration, and so it's somewhat reminiscent of those morials that I showed you in the last case. But let's keep looking around. These are, not quite round, so it's not quite perfect for moriolar metaplasia. And then something else that we did not see in the moriolar metaplasia are mitotic figures. And some of these mitotic figures are atypical. So what's going on here? If we keep looking around at these fragments, we can see that some of them have um, abundant pink cytoplasm and then well-defined cell borders. This looks very squamous to my eye. And so this brings up the differential. Are we looking at some sort of squamous proliferation? Well, we know that you can get squamous differentiation in endometrioid carcinoma, so maybe that's a possibility of what we're looking at. So we'd want to make sure that we don't see any glandular components here that meet criteria for adenocarcinoma. Another thing to think about is, could this be coming from the cervix? Could the patient have cervical high-grade squamous intraepithelial lesion or even a squamous cell carcinoma that has grown directly into the endometrial cavity? That would explain why we have mitotic figures here. So with this type of appearance, I don't think this is acceptable as moriolar metaplasia, and I would get a P16 stain or HPV in situ hybridization, or better yet, look at the patient's history to see, do they have a known history of high-risk HPV or any cervical pathology. So this is actually an example of H-cell from the cervix that has grown along the endocervical canal through the lower uterine segment and is colonizing the endometrial lining. This doesn't happen very often, but I do think that it is something to be aware of because it comes with the differential of morular metaplasia, and so you just want to have that in the back of your mind. And then I'll make one comment about the possibility of a primary endometrial squamous cell carcinoma. This is an exceedingly rare entity. I don't think I've ever seen a case that I've convinced myself that that's what this is. So really, I think your differential is between morular metaplasia and an endometrioid cancer that happens to have extensive squamous differentiation. So I think we have come to the 50-minute mark. The rest of the cases that I have are more gestational trophoblastic disease, and so maybe this is a good time before switching gears, or maybe we just um, open the conversation now to any questions regarding glandular proliferations, papillary architecture, or these metaplastic features in endometrial biopsies.
So there's one comment or question in the chat, Joe, with regard to some cases of endometrial, or excuse me, embryonal rhabdomyosarcoma have polypoid configuration with periglandular condensation, sort of like your adenosarcoma case.
Yep.
How would you respond to those cases to make sure that you weren't dealing with that diagnosis?
Yeah, so thank you to the person who brought that up. One of the challenges of doing these types of slide sessions is, I wanted to show a lot of cases, which means I can't cover everything about each entity. So if I were to have a little bit longer discussion of adenosarcoma, the point that is raised is absolutely important to consider. What is the differential diagnosis here? And embryonal rhabdomyosarcoma definitely is something to think about. Anytime that I'm about to diagnose adenosarcoma, I order a Desmond stain to look for myodifferentiation, and I order either myogenin or myod1 to look for rhabdomyosarcomatous differentiation. Um, uh, I think, most of the time if you're convinced that what you're looking at is adenosarcoma, that's what it is. Rhabdomyosarcoma of the uterus and of the cervix is exceedingly rare. There are some clinical contexts that can be helpful. So the anatomic location. So here we are talking about endometrial based pathology. And so rhabdomyosarcoma of the uterine corpus is really a disease that you're going to see in the postmenopausal setting. So the patient age is important. Um, if, however, we were looking at a vaginal or a cervical biopsy that had these features, we probably would be thinking about a uh, pediatric age range because that's who gets rhabdomyosarcoma. And the other thing that we would need to think about is Dicer 1 syndrome because many of these cervix-based embryonal rhabdomyosarcomas actually represent probably not rhabdomyosarcoma, but probably what's better called Dicer 1 sarcoma. Those often have areas of chondroid differentiation, and it's really the patient age of them being pediatric age that should alert you to the diagnosis. But I think regardless of the patient age, it's a really great point that the person raised. Um, obviously you want to look for the morphology of rhabdomyoblastic differentiation, but I have to say that I've been surprised both in this setting as well as in carcinosarcoma. Carcinosarcoma is another scenario where I always order myogenin or myod1 because many of those primitive looking uh, spindle cells can actually represent rhabdomyosarcoma, which is going to, potentially change the prognosis there. So even if I don't see strap cells or cross striations, I do think it is a good idea to always order myogenin or myod1.
Here's another question with regard to the squamous cervical lesion. Uh, she asks, if you have H-cell that extends into the endometrium, in other words, with that extensive sense of growth, why would you not consider that squamous cell carcinoma? And obviously not invasive, but
Yeah,
does that
that's a great
extension?
question.
Yeah.
Yeah, that's a great question. And so the way that I would look at this is that if the H cell is just crawling along the endocervical canal, that's not invading the stroma of the cervix. If it then continues to extend up into the lower uterine segment and only colonize the endometrial lining, it's the same thing. It's only replacing the endometrial lining. In order to call it squamous cell carcinoma, you need to see those tumor cells invading into the myometrium in a destructive pattern, often with desmoplastic reaction. And so it's a very rare phenomenon. We see the same phenomenon with primary endometrioid carcinoma that can crawl through the cornu into the fallopian tubes and get into the fallopian tube mucosa without actually invading into the submucosa. So, getting back to the original question, in order to call something squamous cell carcinoma, it needs to have gone beyond the basement membrane of the epithelium, and so it needs to have breached through and gotten into the myometrium.
So, my experience with papillary proliferations of the endometrium is very limited, um, because I think it's a rare occurrence, a rare entity. But is that a situation where any of those immunostains would ever be useful?
Um, that's a great question. Um, I believe that the triad of those immunostains of PAX2, PTEN, and CTNNB1 have not looked at cases of papillary endometrium that I can recall. So the answer to your question is I don't think there's any literature on this. I would not, however, expect that those markers would be helpful. But let me back up and say, is your question to separate PPE from atypical hyperplasia? Is that
Yeah,
the
that's really the
question that you were
question.
getting
Yeah.
at? Yeah. So um, the question is, what's the sensitivity and specificity of those markers in PPE? My recollection from the papers is they've looked at metaplasias, they've looked at progestin-treated epithelium, and they've looked at just garden variety atypical hyperplasia. I can't recall that they tested PPE. I would assume that those markers should not be altered in PPE, but that's not a good way to practice by assumption. So I think it's something that I just wouldn't do. And I have to say, uh, even though my institution has an amazing library of immunostains, I'm actually very wary of using immunostains because most of our literature historically is based on routine H&E. And so I think you have to be very, very careful about relying too much on biomarkers. I see this in sometimes our community practices where people are making diagnoses only because of a result of an immunostain when the H&E morphology doesn't fit. And I think that that is a problem. You want to have your morphologic findings be very, very strong for whatever entity you are considering, and then very cautiously use your immunostains to validate what your suspicion is. But to just do a bunch of immunostains and say, oh, these are abnormal, this has to be atypical hyperplasia, I'm not sure that's what the original intent of the authors were
Yeah.
from those papers.
And I think that same caveat is going to apply even more so as we start to bring in AI tools. That
Yep.
we just don't know on some situations because it hasn't been evaluated in those settings, and we want to extrapolate because that's where our problems are, but it doesn't always work. So we got a couple other questions. So Dr. Sarer-Roit, you had a question. You want to speak up?
Yeah. Good evening, Professor Dr. Hassan and Dr. Rabban from Cambodia. And I have two questions concerning serous adenocarcinomas in endometrium. Normally, do you need immunohistochemistry for metadiagnosis or not?
Okay, so that is a great question. For the diagnosis of endometrial serous cancer, should we be doing immunohistochemistry? And here I have the opposite answer, which is yes, you do want to confirm the diagnosis because there is a possibility of overdiagnosing serous carcinoma when you have benign metaplastic changes such as tubal metaplasia. I've seen sometimes that get overcalled. So um, the data shows that there should be a TP53 mutation in endometrial serous carcinoma, and therefore we would expect the P53 to be aberrant. If you did the stain and it was a wild type result, I would be wondering, why is that result happening? Maybe I am making a misinterpretation. Um, I will say though, uh, in my mind, I am thinking more about the setting of an atrophic biopsy in a postmenopausal patient where I'm seeing mitoses, maybe some macronucleoli, but it's a very atrophic type of specimen. That's really where I want the P53 to help confirm. If you have 4 cassettes of tumor and it looks like classic papillary solid, um, maybe some glandular tumor with severe pleomorphism, and you see atypical mitoses, that's a different situation, because there I think you have overwhelming features that are classic. And I would say, particularly if you are in an environment where you have limited access to immunostains, I think it's okay in that specific setting. It's more
And
if you're dealing with minimal serous carcinoma in an atrophic setting.
and how about the P16? Is really useful or not?
That's a great question. So in theory, when there is a P53 mutation, in theory, there should be overexpression of P16. The problem is that's theoretical, and in real life, you often do not get block positive P16 when you have aberrant P53. We see this a lot in ovarian high-grade serous carcinoma, where maybe somebody in the community ordered a P16 and it just has a patchy staining pattern. So no, I would not use P16 for endometrial serous carcinoma. I would not use it for ovarian high-grade serous carcinoma.
And I have
The
another question.
P53 is
Yeah.
enough. Yeah. But
Okay.
can I make one other point? Um, we now know, because of the TCGA data and molecular data, that it's possible to have TP53 mutation in endometrioid cancers, sometimes in low-grade carcinomas. So coming back to my original point, just because you see aberrant P53 staining doesn't mean it's serous carcinoma. You have to look at the morphology, because some low-grade endometrioid cancers actually do have aberrant P53. Sorry to interrupt.
So we've got two more quick, well, I don't know, hopefully they're quick questions, but how do you differentiate low-grade endometrial stromal sarcoma from, say, just a exuberant stroma or a stroma predominant adenomyosis or something in that situation?
Yeah, that's an excellent question, and the answer is there is no answer. So basically, it's a judgment as to how large is the fragment. That's really what I'm looking at. Because, as you said, Dr. Hassel, there are some times where a funny cut, a tangential cut of the endometrium may make it look like it's mostly endometrial stroma, but those fragments tend to be small. So I think that my my final answer is, how big is that piece of tissue? If it is a chunk of tissue that looks significantly larger than the background endometrial glands or other pieces of tissue, that's where I would be concerned. However, I wouldn't use that as a top line diagnosis. I would simply say there is abundant endometrial type stroma, see comment, and then I would say, here's the possibilities of what this could be.
Yeah.
Endometrial stromal nodule, low-grade ESS, or just a funny cut.
Another really good question. In cases where you have sort of mixed carcinomatous features, so some conventional endometrioid and serous carcinoma, is there a specific percentage that you should be looking at, or how would you word that situation where you have, a focal TP53 mutation, but not everything?
Yeah, so that's probably about a half-hour answer that I have. I would need 30 minutes to discuss this, but the bottom line is it depends if you're talking about a biopsy or a hysterectomy specimen. Because one of the things that the WHO says is that a mixed carcinoma has to be spatially demarcated components. So the lower grade endometrioid cancer, you have to be able to visually see that it is demarcated from the serous or the clear cell carcinoma. That's easy to do when you have a hysterectomy specimen. Um, because if the two components are blended together, it's very possible that you're not looking at a mixed carcinoma. You're just looking at morphologic differences in a single histotype of tumor. And so what we want to be careful of doing, so why is mixed carcinoma so important? The only combination that matters is when you have a component of low-grade endometrioid carcinoma in your biopsy, because that's a low-risk type of tumor, and a high-risk component like serous or clear cell carcinoma. Because in that setting, the low-grade cancer no longer has any meaning to the patient. It's the serous carcinoma that's the important thing for management. And then your other question that you asked is, well, how much do you need? This is where the data is a little bit limited, but as little as 5 to 10% of serous carcinoma with 90 to 95% low-grade endometrioid carcinoma, that the data shows that patient is going to have the same outcome as if it was 100% serous carcinoma. So you should always be worried whenever you see any of that morphology. On a biopsy, I think it becomes a little bit tricky because you don't know how much, right, that there's actually in the uterus. You're only looking at a sampling. And so I may take a more descriptive diagnosis, and I would say, I see a high grade component, I see a lower grade component, I'm concerned this may be a mixture of serous carcinoma and low grade.
A sort of related question, which I think is a really hard one, is in a curettage, is there ever a point where you can make the diagnosis of endometrial intraepithelial carcinoma?
Endometrial intraepithelial. Oh, you mean endometrial cancer confined to the endometrium? Is that
Yeah,
what you're?
so the high grade, the EIC situation where you have serous carcinoma that is in situ, quote unquote.
Oh, okay. All right. Well, that is a great question to bring up because um, historically, so again, I need another 30 minutes for this, but the short answer is that in the 1990s, there were some papers on minimal serous carcinoma. So serous cancer that only involved the surface of the endometrium or the surface of a polyp or maybe just a few glands, usually under a centimeter in extent. And those papers back in the 1990s, early 2000s, used either the term minimal serous carcinoma or SEIC, serous endometrial intraepithelial carcinoma. Fast forward now to 2026. We now know with the outcome data that those cases behave very similarly to garden variety serous carcinoma.
Yeah.
And so there's a very large camp. It's not 100%, but it's a very large camp of specialists who have taken the position that we should no longer use those terms and we should just call it endometrial serous carcinoma. Doesn't matter that it's minimal. I will say at the WHO last year when we were putting together the 6th edition, this topic came up again, but I think that in an endometrial sampling, if you have morphology that looks like serous carcinoma and there's PVD3 mutation, I would never use the term minimal serous carcinoma. I would just flat out call it serous carcinoma.
Great. I think that's very, very helpful. Well, this has been absolutely wonderful session, Joe, and I'm sure people would love to go on for hours, but I know you have a work day ahead, and as do I. So we'll hopefully perhaps get a return engagement and cover some additional topics and let you go on. But thank you so much for your time and expertise. This has been very helpful. I know that our audience and those who view this later will find it very, very rewarding.
Great. Well, thank you for the invitation, and thank you to all the participants who took time out of your day to be here to look at these interesting cases. Thank you.